Thanks for inviting me today. My name is Sunnie Kim. I'm a GI medical oncologist at University of Colorado Cancer Center. My presentation today is entitled Year in Review, Novel Treatments and Strategies in Gastroesophageal Cancer. And every year we seem to have exciting updates, so I'm happy to present the slides. So first, let's dive into the locally advanced setting for gastric and GEJ cancer. The the long-awaited Keynote 585 study, this was a randomized phase 3 trial looking at neoadjuvant and adjuvant pembro plus doublet chemotherapy versus placebo plus doublet chemotherapy in locally advanced gastric and GEJ adenocarcinoma. And this is the schema for the main cohort. So patients here needed to have T3 or greater primary lesion or the presence of any positive lymph nodes. Obviously, no prior therapy and deemed to be a surgical candidate. They also needed to have provided tumor sample for PD-L1 testing. So they were randomized 1-to-1 to receive chemo plus pembro versus chemo plus placebo. They received this for 3 cycles and then followed by surgery. And then for the experimental group, they received chemo plus pembro and then finished out a year of pembrolizumab at Q3 weeks. And then the control arm was chemo plus placebo. This was a global study, as I mentioned, so stratification factors included Asia versus non-Asia, and we were also interested in looking at the chemotherapy backbone, a doublet chemo regimen versus what we typically use in North America and Europe, the triplet FLOT regimen, and those are for patients who are very robust and typically younger in age. So the primary endpoint with past CR, as well as event-free survival, and overall survival in the main cohort. So, despite some promising initial results where we saw that the path CR rate in the pembrolizumab group was superior to the placebo group, and this was 12.9% versus 2%, and we also found that the event-free survival was impressive, 44.4 months in the pembro group versus 25.3 months in the placebo group. The overall survival did not pan out. It was 60.7 months versus 58 months. And this was clearly not numerically significant and not statistically significant. And you can see that in the Kaplan-Meier curves on the right. So up in the upper right, this was the overall survival in the main cohort. And on the bottom right was the overall survival in the main plus FLOT cohort. And so overall, these were disappointing results, and we cannot recommend using a PD-1 inhibitor in addition to chemotherapy as peri-op therapy for gastric and GEJ cancers. This year at GI ASCO, they also did present the FLOT cohort results. Similarly, we saw a path CR benefit in the pembro group plus FLOT versus placebo plus FLOT, 17% versus 7%. However, when we looked at the overall survival, clearly no difference. These curves are overlapping. And then looking at another study looking at peri-op FLOT plus durvalumab as peri-op therapy. This is a Matterhorn study, which was a global phase 3 double-blind placebo-controlled study. And I want to just emphasize this is a truly global study, which is really important to get representation from all patients with this disease across the world. And so similarly, this was looking at gastric and GEJ adenocarcinoma. Greater than T2 and positive node status. And these patients were randomized 1-to-1 to receive FLOT plus durva versus FLOT plus placebo perioperatively. And in the experimental group, durvalumab was continued for a year. And here we have results for the pathological CR rates, and but the primary objective is event-free survival, which we do not have results yet at this point. So similarly to what we saw in Keynote 585, on the left over here, we are seeing a path CR benefit numerically. 19% versus 7%. And then there was a nice presentation in January where they looked at the path-CR differences in different regions of the world: Europe, North America, and South America. Interestingly, in North America, the difference seemed to be more pronounced, 29% in the FLOT plus Durva group versus FLOT plus placebo. However, it's important to note that when we look at the numbers, the number of patients in the North America group was relatively smaller at 82 patients versus Europe and South America. So it'd be interesting to see if this was just this difference, this numerical difference, was just due to the smaller patient population. If that was increased, if we would see less of a difference. And then when we look at pathological response by subgroups, we saw a benefit in many of the subgroups, going down to the PD-L1 expression. It's important to note that in this study, they used something called a TAP score, which is a rougher estimate of the PD-L1 expression. It's thought to be less time consuming for the pathologist. And as the PD-L1 expression increases, we're seeing an increasing benefit in favor of durvalumab plus FLOT in terms of the path-CR rate. And then, of course, looking at the MSI high status, patients who had MSI high tumors, they seem to benefit more, but these were small numbers.
Could I just ask, first of all, it kind of is like a backwards forest plot to me in that it goes positive, but I guess you have to look at it the same way. But it kind of, even when I look at like MSI high versus non-MSI, I mean, it kind of doesn't seem that much different. I don't know. It seems pretty counterintuitive.
Mm. Yeah, I mean, it does look like the odds ratio is higher than the non-MSI high cohort. I suspect because of its very small patient numbers. That's why the confidence interval is seems wide here. Um, I've had this discussion about the GEJ cohort because there's a thought that the GEJ patients may overall be doing worse in terms of survival and clinical outcomes than the gastric cancer cohort. But first of all, I think it may be a surrogate for some other negative prognostic feature, or again, the GEJ numbers are typically much smaller than the gastric cancer numbers. So I find that it's really hard to make any big conclusions when we look at these forest plots, especially if the patient number in the group is quite small.
Well, I mean, the thing that I really am curious about is the PD-1 level. That's the only reason I'm really asking about all this, because, like,
Mhm.
again, everything's to the right, regardless, right? It's all to the
Right.
right. So maybe it's a
Mhm.
little bit more to the right than, with I don't know. It's just, I mean, do you really think the
Yeah.
PD-1 is not relevant?
No, I think it actually is probably relevant. But yeah, we're seeing kind of like an overall trend more to the right here. But the other thing too is when the PD-L1 expression, when they say greater than 1%, I want to know what percent of those patients are like PD-L1 5 versus most of them being a PD-L1 score of
Of
like 10
course,
or
of course.
50. Yeah.
But they
Hmm.
do, but they do have, five and over and under, whatever. But let me just ask you,
Hmm.
because I've asked other people this, because people go, oh, PD-1 doesn't matter. And of course, obviously, we're waiting for more data, particularly the Matterhorn. Hopefully,
Right.
it won't be the way the Pembro study is. But right now, like, I don't know, how often do you see patients who, let's say, have a PD-1 greater than 5? What percent of them are like that?
I would say about 40% of my patients.
Okay, and how about over
Hmm.
10?
Over 10, 20%.
Okay, so let's say you have somebody who has a PD-1 over 10.
Hmm.
Would you offer, maybe an educated patient, a doctor, whatever, would you offer PD-1 to them, or you need more data?
In the peri-op setting.
Yep.
Yeah. I think at this point, I have no strong data to support that. We can look at these forest plots, but it's hard for me to make big treatment decisions like that based on a forest plot, even if there seems to be a better association. And unfortunately, with Keynote 585, because we're not seeing that overall survival benefit. It's hard for me to expose a patient to an immune checkpoint inhibitor in the peri-op setting, risk getting a severe immune-related AE, and then potentially sabotage their chance of getting to surgery or getting through the standard treatment.
How about if I say, what fraction of these patients are going to get an IO for metastatic disease within 6 months or a year? And why not try
Um,
now?
right. So I think the majority of patients at time of recurrence will get an immune checkpoint inhibitor. I am still pretty stringent on the PDL1 status. If it's 5 and higher, of course, I'll give it to them. If it's lower than that, it's really hard for me to justify it now that we have multiple phase 3 studies in the metastatic setting showing no clear benefit.
But when you say you give it, are you talking about gastric patients who get FLOT?
Who have previously gone FLOT. Yes, if they
With
become
res-
metastatic, then I would.
no,
Well, it
yeah, but
depends
what
on
I'm
when they
saying
recur.
is, yeah, but I'm talking about patient with a residual disease after neoadjuvant FLOT and a high
Oh, I
PD-1
see.
level.
Yes. I think it's still really hard to justify that based on the 585 study that we have right now. I'd be interested in seeing what the Matterhorn shows, if there is a difference there, but that is not my practice right now to add a PD-1 inhibitor. It's very hard because before the 585 came out, I was adding a PD-1 inhibitor if there was no clear pathological response at the time of surgery. But now I find it very difficult to justify that.
Right. No, I mean, I don't know what the right answer is. I'm just trying to kind
Yeah.
of get into the psyche of the patient. But again, you have a patient with substantial residual disease after getting neoadjuvant FLOT. What's the chance
Mhm.
they're going to have metastatic disease in the next 2 years?
I think it's very high. I have had patients who have had horrible path results at the time of surgery, T3 and 3, and we really twist. We're very anxious about giving the same regimen, but for now that's what I've been doing. And I do have one patient who's a year out and still hasn't presented with metastatic disease, and so I do wonder if sometimes these path results are necessarily our gold standard to determine adjuvant therapy, because I wonder, because there are some patients who have had clear clinical response, but the pathology results at the time of surgery are horrendous. But we can't ignore that the scan looks better, their symptoms got better. So I wonder if the cancers that had died, we're not seeing evidence of that on the pathological review. So it's still hard for me to justify changing the therapy or not even offering them adjuvant therapy, even with a poor prognostic pathological review at the time of surgery.
I guess this is the time where I go, do you ever use ctDNA in this situation?
So I've used ctDNA to potentially de-escalate treatments when a patient has had a very difficult time with neoadjuvant therapy. They've gone to surgery and there's a great response, say like a path CR, and I'm concerned about giving them adjuvant therapy. I have been using ctDNA in very select cases. If a patient is not wanting to go to adjuvant therapy, I'm very concerned about their safety. If serial ctDNAs are negative, then I may kind of avoid adjuvant therapy altogether.
Yeah, I was just kind of curious if you ever did ctDNA in that situation where the pathology was positive, but like you were saying, they had a great response. Maybe they don't really have viable tumor. I don't know. Maybe their ctDNA would flip to negative, but I don't know.
Yeah. The problem with the current assays, I think the sensitivity is still quite low
Hmm.
than I would be comfortable with. I was just talking to one of the companies that does ctDNA testing, and then I think we've realized that ctDNA by itself is not good enough, obviously, because there are some areas in the body where the ctDNA shedding is poor, say in the brain, in the lung, in the peritoneum, and these are all potential sites of metastases. And so I think we need to pair it with perhaps different technologies, methylation assays, to really get a full sense of the MRD status.
Just out of curiosity, any reason to think that like colon would be a better use of ctDNA than say gastric? Does it shed more?
Yeah. I don't know fully, but some of my theories is that the sites of metastases for colon cancer, it often spreads to the liver, um,
Hmm.
and it doesn't spread as much the peritoneum as gastric, I would say.
Hmm.
And I wonder if it's more the sites of metastases that are driving, the sensitivity of the ctDNA assays.
That's really
But
interesting.
don't
I
hold
never
me to
thought
that.
about that. Yeah.
I don't want to speak out
No,
of
but I
out
mean,
out of line about that. Yeah.
yeah, no,
Mhm.
but I mean, I would think they could have looked at that, in terms of ctDNA positivity based on at least macro wise where the Mets were.
Right.
But you were saying that you think maybe what peritoneal is less comes out less, sheds
Yes, that's
less.
for sure. It that does shed less. The ability for that ctDNA to go into the bloodstream is definitely less than other sites of metastases.
That's really interesting. Please continue.
So then going into the mismatch repair deficient and MSI high resectable gastric and GJ cancers, just want to present some background here. This was a brilliant study by Lizzie Smith, where she did an exploratory analysis of the MAGIC trial. As a reminder, the MAGIC trial was peri-op ECF for resectable gastric and GJ cancers. And in a secondary post hoc analysis, they looked to see what the role of chemotherapy or surgery alone was in these MSI high mismatch repair deficient tumors. And so, of the 503 study patients, the number of patients with mismatch repair deficient or MSI high cancers was very low. As you can see, the numbers 7.6% for mismatch repair deficient and 6.6% for MSI high, but they did do this analysis. So, looking at this curve, this Kaplan-Meier curve over here, on the very top, that gray line, this is the MSI high tumors that had received surgery alone, no peri-op chemotherapy, and these patients seem to do the best in terms of survival. And then when we look at the yellow line, these are the tumors that are MSI high that had received chemotherapy, peri-op chemotherapy, and they seem to do the worst in terms of survival. And then when we look at the two middle curves, these are the MSS cohorts. So, as expected, when you have an MSS tumor and you receive peri-op chemotherapy, the survival seems to be a little bit better than MSS tumors that had not received any peri-op chemotherapy and went to surgery alone. And so, this really raised the question when it first came out about with our patients with locally advanced MSI high gastric and GEJ cancer, should we be offering them peri-op chemotherapy or just taking them straight to surgery? And there was a lot of debate here. My preference had been to take them straight to surgery or try to get them enrolled in a clinical trial because of this post hoc analysis. But it was very hard to make any final conclusions, especially with these very small numbers. And so we have some more answers now in 2024 with the NeoNapiga and the Infinity trials. These trials were looking at neoadjuvant or perioperative dual immune checkpoint inhibition for locally advanced resectable MSI high and mismatch repair esophagogastric adenocarcinoma. So this is the study schema for NeoNapiga. This was a phase 2 trial looking at neoadjuvant ipi-nivo. So the ipi-nivo, the way it was given was nivo 240 milligrams every 2 weeks, and the ipi was 1 mg per kg q6 weeks. And this was given for 12 weeks, followed by surgery, and then they completed nivolumab for 9 months. And the prime endpoint here is looking at the path CR rate. And the secondary endpoints, we have some initial results on that. And so this was a study schema for Infinity, similar, although most of the treatment was given before surgery. So in this study, it was tremelimumab, which is a CTLA4 inhibitor, and durvalumab, a PDL1 inhibitor, and that was given for 12 weeks. And then the patients were restaged with a CT and PET scan, an endoscopic ultrasound with multiple biopsies, and also liquid biopsy. So for the patients who, in cohort one, those were patients who all went to surgery, which would be more of the standard of care. But then for cohort two, the patients were randomized to surgery if they had an incomplete response based on the restaging tests, and then another group of patients were randomized to non-operative management if they had a complete response based on the restaging PET, CT, and endoscopic ultrasound with multiple biopsies. And those patients in the non-operative management group were intensely followed up, and that intense follow-up was defined as getting a CT chest, abdomen, pelvis every 12 weeks for 2 years, in addition to an EUS with multiple biopsies every 12 weeks, as well as an MRD liquid biopsy test. And then, interestingly, when we look at the pathological complete response rate in both of these studies, so on the left over here, the NeoNapiga study, the complete response rate was 60%, and on the right over here in the Infinity study, also 60% as well. So it's really interesting. Even with different immune checkpoint inhibition, we're seeing nearly identical results. It's important to know the NeoNapiga had a few more patients. The patient number was 29 patients, and Infinity, this was 18 patients. And then for the two studies, when we look at the 1-year survival rates for NeoNapiga up on top over there, the event-free survival was quite good. And the OS over here, there was one event, and that was unrelated to disease recurrence, as far as I remember. And then in the below Infinity, also seeing very similar results, very good overall survival rates for these studies.
So I'm curious how these data compare indirectly to data with single agent IO, and also what you do in your practice if you encounter this situation and there's no trial available.
Right. So for patients with locally advanced, at this point, I'm not offering them single agent IO. Either I'll do chemo plus IO if I'm very concerned, if they're very symptomatic, and I want them to have clinical relief sooner than later. But if they're relatively asymptomatic or have very minimal symptoms, I will go with a dual immune checkpoint inhibition strategy.
And again, indirectly, how would you compare the findings when you use dual inhibition versus, let's say, single agent?
Yeah, I unfortunately have had no experience with single agent for these patient populations. So
So it's not been studied.
I
There's
can't
no
speak.
phase two. There's no phase two of single agent IO.
Just peri-op
I mean, I don't
single
know.
agent.
I don't know. I'm
I'm
just
not.
asking.
No, I'm not aware of that. If there is, it may be a very very small study, but
Well,
gosh, I feel like that'd be
I
hard
mean,
to
let me.
get through IRBs. Yeah, single agent.
Well, I mean, let me. Isn't that what they used in the rectal study at a memorial?
Um, I believe they were
Dostarlimab,
using
right? I think they were
dostarlimab.
using
Oh, across
dostarlimab.
diseases. I apologize. I thought you meant just in gastric and GEJ.
Well,
Yes.
yeah,
Yes, correct. Yeah, the dostarlimab data in rectal cancer was very impressive. I would say that that data probably is a little bit better than what we're seeing in gastroesophageal. Although with dostarlimab, I feel like the patient numbers were a little bit higher there. Yeah.
but I mean,
Mhm,
but what I'm saying is, again, getting back to gastroesophageal. So you
mhm,
have, I mean, I know it's a different location, but you have, a situation where they use single agent IO and rectal. I know it's different, but
mhm.
do we at least have data with single agent IO in the gastric? Is
I'm
it
not aware of
low?
that data. I'm not aware.
Well, maybe yeah, because maybe, like you said, maybe nobody wants to do the study because they might consider it
Yeah.
unethical.
Yeah.
So, okay, that's really. What do you think? Do you think that most investigators are not using, ipi-nivo or in this situation?
Well, that's a great question. It's in one of my patient cases later, but I'm concerned that we're not even doing MSI high testing for newly diagnosed locally advanced patients. I have one patient who actually advocated for himself to get MSI high testing, and that's
Wow,
when they found
wow,
out. Yeah,
that's
so
terrible.
I think that's the first gap that we have to deal with. Just even getting that testing done. And even with that testing done, with two small phase 2 studies, I think it's still hard to convince the majority of the oncology group to go with this approach versus the more tried and true, peri-op chemotherapy approach. But in my practice, I am using an IO based treatment approach. Like I mentioned, either chemo plus IO or doublet IO.
Right. And could you also clarify the difference between MMRP and MSI?
Oh, sure. Yeah. So, mismatch repair deficiency, there are four main mismatch repair proteins that are important for DNA repair. And when we lack one of them, it can make the tumor more immunogenic, where there can be something called microsatellite repeats that seem to prime the immune system to be more on alert and have more of an anti-tumor effect. And so, mismatch repair deficiency causes microsatellite instability. The vast majority of mismatch repair deficient tumors result in microsatellite instability, but I have had some cases where there's been discordance there. And I really rely on the microsatellite instability to make treatment decisions like using peri-op IO.
And where that comes from what? The NGS?
Yes, the NGS. Because you sometimes wonder, with the IHC for mismatch repair evaluation, I mean, they have controls when they do the IHC, but the lack of protein expression, I always get concerned, could that just be a faulty assay that day? And
Hmm.
especially for a patient who doesn't have a strong family history, no Lynch syndrome, I just always want to confirm with MSI testing.
Interesting. Please continue.
So then, moving into the advanced setting, I want to present a series of studies looking at tislelizumab, which is a PD-1 inhibitor. And the first study is Rationale 302, which was a phase 3 study looking at second line Tisli versus chemotherapy, investigator choice chemotherapy in esophageal squamous cell cancer. So these were patients with advanced esophageal squamous cell cancer who had progressed during or after first line platinum containing treatment. And they were randomized 1-to-1 to receive Tisli 200 milligrams Q3 weeks versus investigator choice chemotherapy, which could have been paclitaxel, docetaxel, or irinotecan. And the stratification factors, this was Asia versus Japan versus North America, Europe. And the primary endpoint here was overall survival. So when we look at the overall, the objective response rate, we found that in the Tisli group, it was impressive, 52% versus 25%. And looking at the complete response and the partial response, we're seeing that the majority of these patients are experiencing partial response within the objective response rate group. Um, and the duration of response was 7.1 months in the Tisli group versus 4 months in the chemotherapy group. And there were patients with ongoing response, about 20% in the Tisli group. So this was an impressive study showing that in the second line setting for patients who had not received prior IO, that Tisli was a viable option. And then here, looking at the overall survival, there was a benefit in the Tisli group, 8.6 months versus 6.3 months in the chemotherapy group. And then looking at the forest plot over here, overall in most of the subgroups, we saw an improvement in the Tisli group. And again, going back to the PDL1 status over here, with the TAP score greater than equal to 10%, we saw more of a benefit than, say, the TAP score less than 10%. And then looking at the safety of Tisli versus chemotherapy, actually overall, we found that Tisli seemed to be the less toxic option in the second line and beyond setting. The percentage of grade 3 and higher AEs was 68% in chemotherapy versus 46% in the Tisli group. And then this safety profile seemed to be pretty consistent down the line. That chemotherapy seemed to be harder on these patients than Tisli. So as a result, this is late breaking news. The FDA did approve Tisli for advanced or metastatic esophageal squamous cell cancer after chemotherapy. Um, So these patients are eligible for Tisli if they had not received a prior PD-1 inhibitor or PD-L1 inhibitor.
Another thing I was curious about is, I guess theoretically there's a slightly different mechanism of action here. And, I
Right.
was kind of wondering, and this is one of the things we were curious about. Every time you ask people to indirectly compare IOs like this, they always go,
Hmm.
oh, they look about the same. It's like CDK and everything else where you have multiple things. And,
Hmm.
I kind of wonder, and I know people have asked me too, and here you have, a slightly different mechanism of action. Like if it were, 20 or 30% better, would we even know it?
Right. Yeah, my approach is, looking at the hazard ratios between these studies, especially if they're very similarly designed or, identical design. And I did take a look at that, and the Tisli trials look a little bit better in terms of hazard ratio, but not enough to make me really wonder if because of this slightly different mechanism of action, if I should be using this over nivolumab or pembrolizumab. I think truly the only way to know is do a head-to-head comparison, and that's going to be difficult.
Right, and probably not
Hmm.
really worth the effort. But
Right. Hmm.
also another thing that we've seen has been kind of interesting that I think a lot about is what I call the Pacific trial effect, which is
Mm.
in non-small cell lung cancer, Pembro is first line either with or without chemo, totally all over the place. And then all of a sudden, a trial came out in the post chemo radiation there with Durva that was very
Hmm.
positive, great long
Right.
term data. Everybody, and the Pembro trial didn't look as good. So
Hmm.
people are like, okay, so now everybody uses Durva because they have this general feeling that they're globally about the same to start with. So it, kind of feeds
Hmm.
into that. So I guess my question is that the way you think a drug like Tisli would sort of get used? Like if some trial, phase 3 trial, combined it. I know there's one with the anti-HER zanidatamab. There,
Right.
I guess whoever gets the best data is the one who gets used. Is that kind of the way you think this is?
I agree too. I think these studies, it's not going to move the bar significantly to get their drug used in similar indications as Nevo and Pembro. But I think if they're really able to capitalize on the combination clinical trials, and there's clearly a benefit there, I think that's their opportunity to really that's our opportunity to really use Tisli. But at this point, the hazard ratios are just slightly different. I'm not planning on replacing Nevo and Pembro with Tisli for first line ESCC, second line ESCC, or the first line gastroesophageal adenocarcinoma.
And I know you're going to go through some other trials in the metastatic space, and maybe we can sort of talk about how that sort of translates into practice in general for IOs. But let me ask again another general question. I'm always trying to get people in GI to kind of make it simpler, but if you
Mhm.
sort of think about it at a more kind of global level in terms of these IOs in this situation, can you say that if the patient has a squamous cell, esophageal or even lower, that they're generally going to have higher PD-1 levels and generally more benefit from IOs than adenocarcinomas?
Yeah, definitely. Looking at Checkmate 648, the majority of those patients had PDL1 positive tumors. And so nearly all my patients with esophageal squamous cell cancer are getting IO based treatment as soon as possible. And even the patients who are negative, I kind of wonder if I biopsy the wrong site. I mean, it just makes sense in terms of, um, etiology and risk factors. These are patients who are either heavy smokers or, heavy alcohol use. So,
Yep.
yeah, I is
All right,
important for
please
this
continue.
disease. So the next study I want to present is Rationale 306. This was a study looking at first line locally advanced or metastatic esophageal squamous cell cancer. And they could not have received prior treatments. And they were randomized 1-to-1 to Tisli versus placebo plus investigator choice chemotherapy. And that could be platinum plus fluoropyrimidine or platinum plus paclitaxel. And going to the punchline over here, we did see an OS benefit of 17.2 months versus 10.6 months. The hazard ratio here was 0.66. And I'd like to compare that to Checkmate 648, which was a very similar population, identical population, looking at unresectable, advanced, recurrent, or metastatic esophageal squamous cell cancer. And this study, as you probably recall, this had three cohorts. The first cohort here was chemo plus Nivo. The second one was doublet IO, Nivo plus Ipi, and then the final group was chemo alone. And here, we also saw a benefit too with chemo plus Nivo versus chemo alone, and that was 12.8 months versus 10.7 months. And the hazard ratio here was a little bit higher, 0.78. So this was the one study where I kind of wondered, is there a difference between Tisli versus nivolumab? Just because the hazard ratios in Tisli, you have 0.66, I believe, and this one was 0.78. You wonder, but it's hard to make any cross trial comparisons. I know we say that all the time, but this was the one study where I did scratch my head a little bit. And then going into the adenocarcinoma space, this was rationale 305 with gastric and GEJ adenocarcinoma. Patients with HER2 positive tumors were excluded. And they were randomized 1-to-1 to receive Tisli plus chemo versus placebo plus chemo. And the OS here was improved, 17.2 months versus 12.8 months. The hazard ratio here was 0.74. And then when we compare that to Checkmate 649, which was a very similar study, also first line HER2 negative gastric, GJ, and esophageal adenocarcinoma, when we looked at the benefit of chemo plus Nivo versus chemo alone, we're also seeing similar hazard ratio, 0.79. So I think for the adenocarcinoma space, I'm not changing my practice. I'm still using chemo plus IO for the PD-L1 positive tumors, specifically PD-L1 CPS greater than or equal to 5. And then another trial to keep in mind is Keynote 859, which is chemo plus Pembro versus chemotherapy alone. And similarly here, there was a survival benefit and the hazard ratio very similar to Checkmate 649, 0.78. So moving to the biomarker space, Claudin 18.2. As a reminder, this is a tight junction protein that normally is expressed on gastric mucosa cells and seems to be more exposed to the surface in the setting of malignant tumors. And zolbetuximab is a IgG1 monoclonal antibody that targets Claudin 18.2 with ADCC properties. And there was a phase 2 study, the FAST study, which showed that chemo plus Zolbe prolonged survival in a subgroup of patients with higher Claudin 18.2 tumor expression. Spotlight, this was presented in GI ASCO of 2023. This was a first-line study with tumors that were strong Claudin 18.2 expression, as defined by moderate to strong Claudin 18.2 staining in greater than or equal to 75% of tumor cells. And they were randomized 1-to-1 to receive Zolbe plus FOLFOX versus FOLFOX alone. There was also another study, GLOW, which was primarily in the Asian population, very similar, although the chemo backbone was different. In this study, a similar, same population where it was high Claudin 18.2 expressing tumors, and they were randomized to Zolbe plus Capox versus Capox alone. And when we do the comparison between the Spotlight and GLOW trials, overall, I think the magnitude of benefit was similar. Uh, when we go to the PFS, the fourth line over there, in Spotlight, it was 10.6 months versus 8.7 months. The hazard ratio is 0.75. In GLOW is 8.2 months versus 6.8 months, hazard ratio of 0.69. And then going to the median overall survival rates, interestingly, in Spotlight, the control arm did very, very well, 15.5 months. But when we look at the overall benefits still between Spotlight and GLOW, the hazard ratios are nearly identical, 0.75 in Spotlight and 0.77 in GLOW. There was not really a benefit in response rate with the chemo plus Zolbe arms versus chemo alone. And what is of note in the safety is that nausea vomiting is a significant AE and happens during the infusion, particularly in the first cycle. And there was a discontinuation rate of 14% of Zolbe uh, versus 2% in the placebo arm. Not as pronounced in the GLOW trial, but also seen to be higher in the Zolbe arm versus the placebo arm, 7% versus 4%. And going to the rates of nausea, vomiting, anorexia, these are the key adverse events. This was in the Spotlight trial. So we found that nausea, vomiting, and decreased appetite are significantly improved, significantly higher than the placebo plus FOLFOX arm. And when we look at the incidence of nausea, vomiting, it seems to peak with the first dose and then improve with subsequent doses. And then moving on to the HER2 space, trastuzumab deruxtecan. This is an antibody drug conjugate. TDXD is an ADC that has three components to it. It has the part of the drug that binds to HER2, and then there's a linker, a cleavable linker, and then the payload. In this case, it's a topoisomerase 1 inhibitor payload. Destiny Gastric 01, which is a study that really put TDXD on the map for second line and beyond gastric and GEJ cancers. This was a study with patients who had HER2 positive disease, locally advanced or metastatic, that had progressed on 2 or more prior regimens. This was a study done in Asia, and they were randomized 2-to-1 to TDXD at the 6.4 mg per kg dose versus physician choice chemotherapy, irinotecan or paclitaxel. In 2020, the published data showed that there was an improvement in response rate, 61% versus 8%. And the overall survival at the time of publication was 12.5 months versus 8.4 months. We have some updated data on Destiny Gastric 01, and the objective response rate benefit persists, 61% in the TDXD group versus 8% in the physician choice chemotherapy. And in terms of survival, at 30 months, we're seeing 12.5 months versus 8.9 months. So, summary of TDXD. Currently, the FDA has approved it as second line and beyond therapy for HER2 positive gastric and GEJ cancers. There was another study, Destiny Gastric 02, which was a phase 2 study done in Europe and United States. And these were HER2 positive tumors that have progressed on one prior trastuzumab containing regimen. This was the study to really evaluate the effect of TDXD in more of the population that we treat here in the U.S. And fortunately, there was also an impressive response rate, a little bit lower than what we saw in the Asian population, 42%. The median duration of response was 8.1 months, and the median PFS was 5.6 months. And there is an ongoing Destiny Gastric 04 study looking in the second line RAM paclitaxel versus TDXD.
Could you talk about what they saw there in terms of interstitial lung disease, and also what you think about this duration of response being, 8.1 months, given that, it's a small number of patients. But, in other tumors, particularly breast cancer, one of the things you hear about TDXD clinically is prolonged responses. So is 8.1 good for this situation?
Right. To answer the second question, I think we have known that HER2 positive gastric cancer is a very different beast than HER2 positive breast cancer. The HER2 expression in gastric cancer cells just looks even different than in breast cancer cells. It seems to be more scattered HER2 expression for gastric cancer cells. In breast cancer, I think it's more diffuse expression. So that's likely the reason why it seems to work better in breast cancer. And then in terms of the interstitial lung disease, that's always been an issue with TDXD. There have been deaths in the TDXD group with ILD, unfortunately. And my practice has been if a patient starts having any cough or mild shortness of breath, I'm very quick to hold the drug and do an evaluation because of this grade 5 issue with ILD and death in all these studies involving TDXD.
I wanted to ask you another question about zolbetuximab. I didn't want to interrupt you before, but I'm curious what your thoughts are, assuming it does become available, in terms of
Mhm.
what you would do with a patient who's both Claudin positive and PD-1 positive.
So I think the right answer is to go more with the chemo IO approach with the PD-L1 positivity. We have longer term data there. There seems to be a tail in the curve. The tail in the curve is for a minority of patients, only 10% of patients. But that would be my approach. But to be honest, I'm going to see if I can try to get both for patients, Zolbe plus an immune checkpoint inhibitor. I'll let you know if that works. Yeah, once it gets
Right. No,
approved.
I think a lot of, yeah, no, that's what I was thinking you were going to say. But yeah, I think a lot of people are going
Hmm.
to try that. The other thing that I'm really wondering about is the nausea and vomiting that's seen with this
Hmm.
agent, because I keep hearing that it's very, very different. What's your experience?
Yeah, for the patients who don't have a stomach, the nausea vomiting seems to be a little bit better because
Hmm.
that Claudin 18.2 expression that's revealed to the surface isn't present. And it seems to be worse with patients with intact stomachs. I am concerned about the nausea vomiting in the practical setting because despite maximal antiemetic therapy, I think they still ran into issues with nausea vomiting in the chair. And so the recommendation is to stop the infusion and then slow it down at half rate. But then, that chair time is going to be killer for a lot of infusion centers. And I do wonder if patients and oncologists are going to be really gun shy to continue its use if they experience a really horrible side effect with the first cycle, and if they know they may need to continue at the slower infusion for future cycles.
Does lowering the dose help? Not just
I
not
think it
just
was
slowing it down, but actually lowering it.
right,
Does that matter?
right. My impression that it was more lowering the infusion rate that helped, but
Right.
perhaps lowering the dose may also be helpful too.
All
Mhm.
right. Please continue.
And then I want to talk about zanidatamab, which is a pretty exciting bispecific antibody for HER2 expressing cancers. So, as background, zanidatamab, it targets two distinct HER2 epitopes, and it results in HER2 binding across a range of expression levels from low to high. And there is thought to be an ADCC effect with this drug. So this was a first-line study of doublet chemotherapy plus zanidatamab in HER2 expressing gastroesophageal adenocarcinoma. They had three groups: zanidatamab plus Capox, zanidatamab plus FP, and zanidatamab plus modified FOLFOX. And what we found here that the objective response was seen in a majority of HER2 positive cancers, and you can see the waterfall um, plot here over here. And then when we look at the individual groups and the response rate and duration of response, it was a little bit different from group to group. So I actually found that the Zani plus Kpox group, the response rate was 89%. Again, these are all small numbers, so hard to make any big conclusions. And in Zani plus FOLFOX, it was 67%, and then Zani plus FP, it was 100%, but that was only two patients in that group. When we look at the disease control rate overall, seeing that the majority of the patients were able to have disease control, and the median duration of response, 10.4 months in the Kpox plus Zani group, and then not evaluated in the Zani plus FOLFOX and the Zani plus FP groups. When we looked at the progression-free survival in the HER2 positive gastroesophageal adenocarcinoma and the overall survival, for PFS, we saw that to be 12.5 months, and in the overall survival plot over here, the median survival was actually not reached at that point. So the most prominent side effect of this drug is diarrhea. And there is an ongoing phase 3 study, as we alluded to before, the Horizon GEJ-01 study, where they're looking at Zani plus chemo plus minus tislelizumab, depending on the PD-L1 status. And this will be for the first line treatment of HER2 positive gastroesophageal adenocarcinoma. So that's my presentation. I have some cases. Mhm.
Yeah, before you get to the cases, just I don't know, for some reason, I mean, I've heard people say that they see diarrhea with a Zani before, but all of a sudden, I just sort of flipped into pertuzumab for some reason because, of course,
Mm.
that's associated with diarrhea. Do you know whether or not Zani hits something similar to pertuzumab? Do you think that could be the mechanism?
It's a possibility. I mean, we do sometimes see diarrhea with trastuzumab as well. So I think hitting that
Hmm,
HER2 can be a risk factor for causing diarrhea.
interesting. All right, let's talk about your cases.
Oh, great. Yeah. So I alluded to this patient before. These are all real patients of mine. So this is a 55-year-old man who initially presented with abdominal pain, bloating, reflux for 4 months. And then he went and got an EGD after a few months of these symptoms. And he found a large ulcer in this 6 centimeter ulcer in the gastric fundus. The pathology had a lot of poor prognostic features. It was poorly differentiated, diffuse type signet ring, but also had loss of MLH1 and PMS2. And this is the patient who actually advocated for getting MMR testing and MSI testing. And we did
Wow.
confirm that the tumor was MSI high. And so his oncologist looked at the Neo-Nepega study and did start him on ipilimumab, nivolumab. So he ended up actually switching care to us because he just really wanted to work with someone who was really up on the literature with MSI high and MMR deficient gastric cancer. So after 3 months of treatment, 12 weeks, he had a CT chest, abdomen, pelvis, which showed interval decrease in size, near complete resolution of the gastric wall thickening. This is a patient who knew that if he went to surgery, it would be a total gastrectomy. And he was not mentally prepared to have that kind of surgery. And so, very well educated. He has looked at the primary literature for all these studies. And so, after much discussion, we decided to continue IO and reassess again. He had some new dyspepsia, so we decided to do a PET scan a little bit on the early side, and we found that on the PET scan a month and a half later that there was no FTG-avid disease. And at the very beginning, his disease was FTG-avid. Sometimes with the signet ring diffuse type, it may not be as FTG-avid, but for him it was. And then I recommended we also get an EGD too. And there was no obvious visualized disease, and biopsies were taken. And this is late breaking news, but the pathology was negative for malignancy. There were
Wow.
no signs of cancer on biopsy. So now we are in this interesting situation about what to do. Should we continue IO? Should we take him to surgery? He's young, very fit. He could easily tolerate the surgery. And he's talking to other patients to see what the surgery is like and what life is like afterwards. But gosh, I wish this was 2 years later where we had results from the Infinity trial, because the Infinity trial did have some data in the watch and wait cohort. So it'd be nice to know. But at this point, I am still recommending surgery. Given his good physical condition, but it's a very interesting question about what to do with these patients who have had such great
Cell-free
response.
DNA?
Yeah, so I've mentioned doing that, although I've had enough disappointing cases where the ctDNA has been negative, and we've had residual disease at least pop up, say a year later. So
Yeah, no, I
mhm,
was just
yeah.
suggesting that in case if it were positive, it maybe be helpful. I don't think
I
it'd be too
see.
helpful. I don't think it'd be too helpful if it was negative, but maybe it was
Correct.
positive. Maybe he'd be more inclined to think about surgery. I don't know. I'm
That's right.
curious too. What was his background that he found out about MSI and was so proactive? What kind of work does he do?
He's a lawyer. Yeah. He's a
Interesting.
lawyer. He's very
Interesting. Huh.
used to digging through a lot of literature.
Huh.
Mhm.
Interesting. And another thing is, I mean, would sort of consolidation radiation be a consideration?
Well, it's more distal, more gastric cancer. I tend not to do as much radiation for those patients. If it was more GEJ esophageal cancer, yes, we've done that in the past with our mismatch repair deficient tumors, because that is still the standard of care there.
Let me ask you something. I'm still thinking about that data you were showing about chemo, the old data. What do we know about response to radiation therapy in MSI high? Same, better, or worse?
That is a very good question. I don't think we have robust data in that situation. It's interesting with the radiation question. I have a clinical trial right now in the second line and beyond where we have radiation IO and a PARP inhibitor. Um, and radiation. does induce neoantigen presentation. And it kind of makes you wonder in the mismatch repair deficient tumors if we're if certain doses of radiation, not ablative, maybe subablative doses, could help with that presentation and help with an anti-tumor response. But the chemo radiation that we use for esophageal cancer in the curative setting, these are very high doses, which could potentially suppress the immune system, and I do wonder if that's negating the effect of the immune response in the MSI high tumors. So to answer
So
your
my,
question, I don't know. I don't think we have data here, but there are a lot of theories.
all right, let's go
Mhm.
to the next patient.
So this is a 72-year-old man with HER2-positive GEJ adenocarcinoma. He initially presented with dysphagia, iron deficiency anemia, and EGD was done showing a large fungating mass with bleeding in the distal esophagus. HER2 testing was done. It was 3+ on IHC, also mismatch repair proficient. A PET scan unfortunately showed metastatic disease, multiple FDG avid, mediastinal, upper abdominal lymph nodes, and liver mets. He was started on FOLFOX trastuzumab. So, just of note, in this patient, the PD-L1 status was not known at the very beginning. Just FOLFOX and Traz were initiated. He initially had a good response, but had progression of disease in liver and esophagus after 8 months of treatment. He actually came to my care after that. I repeated an EGD before deciding on the next treatment. I like to repeat biopsies to see if the HER2 expression is still high, and it did show that HER2 was 3+ on IHC, and NGS also showed a HER2 amplification. The PD-L1 score was 0. So he was started on trastuzumab deruxtecan, and he did have his first scan recently, which showed interval improvement in the liver metastases. Um, so far doing well, but I am thinking about that. Destiny Gastric 01 and 02 data, where the duration of response is, I would say, modest. So we'll see how long the treatment lasts for him.
Just out of curiosity, did you pre-medicate him for nausea and vomiting? Did he have nausea and vomiting with it?
Yes, he has been pre-medicated. He actually flew through FOLFOX trastuzumab very well. Pretty much had no symptoms, but with TDXT, he's having more symptoms, more fatigue, more nausea.
And what are you doing to screen for ILD? Just ask him, clinically, or are you doing scans?
Uh, Asking clinically in between scans, and if there's any scan that's concerning for ILD, then I have a very low threshold to stop treatment and refer him to pulmonology. I know that pulmonology referrals are not always available in many settings in the United States, so that is a luxury that we have here right now.
I got to tell you a funny story. I love this case because it's like a case that was presented in one of our programs by Doc in Practice when trastuzumab chemo and Pembro had just been approved.
Hmm.
And at that point, it was approved for everybody, regardless of PD-1, because 85% of the people were PD-1 positive. And so this
Hmm.
doc presents this case, but like your case, the PD-1 was 0. And
Right.
so he said, well, it's approved. I'm going to give it. And I was thinking to myself, it's only 15% out of a small number. I wonder if it even works. And then lo and
Mm.
behold, I guess when they finally got around to the approval, it was only PD-1 positive.
And there was a detriment in the PDL10 group too. Um,
Oh, I didn't
yeah,
realize that. That's
yeah,
interesting. All right,
yeah. Hmm.
that's interesting. Let's see the last case. We actually got two
So
more.
this is another fun case of mine. This is a patient with recurrent stage 4 PD-L1 positive GEJ adenocarcinoma, 66-year-old man who presented with dysphagia to solids. An endoscopy showed a mass in the GEJ extending into the cardia. On EUS, it was T3N0. PET at that time was negative for metastatic disease. He undergoes the standard treatment paradigm, chemoradiation followed by surgery. Unfortunately, a year and a half later, scan shows 2 new liver mets and biopsy. This was biopsy confirmed disease recurrence. The PDL1 score was high, CPS of 20, but this was before the checkmate 649 data and the Keynote 590 data had really come out. So when he was first diagnosed with the recurrence, he started on FOLFOX, and then he had moved from California to Colorado. And once we were able to get our hands on nivolumab for first-line treatment, I added Nivo to 5FU. And then he had a series of very stable scans. And he was the one who first brought up, well, I've been quite stable now. My disease has been quite stable now for several years. What's the next step? And so I brought it back to our multidisciplinary clinic and a conference. And one of our surgeons decided to take him for robotic liver resection August 2021. And he remains disease free until today.
And when they did the resection, they found that tumor?
Yes, they found tumor. And his tumor, his CEA level had always been low level abnormal. And then after the surgery, it completely normalized. He's another patient where after the surgery, we were really hemming and hawing about what to give him after that. Should we continue on with some pseudo-adjuvant therapy or maintenance therapy? This is where we did do some serial ctDNA testing, and it was negative, and so we felt comfortable just stopping treatment altogether.
Yeah, this is what I mean about being interested in an IO with gastric adenocarcinoma and poor response to FLOT, because
Yeah.
the hope, particularly if they have a high PD-1, maybe hidden in there are some people like this man that maybe we
Right.
can't see so clearly. And if that's really the only shot you have, I'd rather do it now than wait for metastatic disease. But that
Yeah.
would be a personal, or not, who knows what people would want to do. But I think that's the logic that people think about, and I can understand it too.
Yes. Yes. I mean, someone with a path of T4 and 3. I mean, that's metastatic at that point.
Right? I think you have one more, right? Let me
I have
see.
one more,
Yeah.
Claudin. Yeah, I can go through that.
Yeah. What happened with
So
him?
this is a 41-year-old man who initially presented to the emergency room with dry cough and new oxygen requirement. A CT chest showed extensive pulmonary nodules, and then there was a subsequent PET CT which showed the distal esophageal wall thickening with Mets to the left adrenal gland. EGD was done. It was biopsy confirmed moderately differentiated adenocarcinoma. So this was a patient who did enroll in the Spotlight trial. His claudin testing did show high expression of claudin 18, and he was randomized to FOLFOX Zolbe. Very classic. He did experience significant nausea, vomiting during cycle 1. The infusion was slow to half rate. Additional antiemetics were administered, and he was able to tolerate completion of the Zolbe. So with maximal antiemetic drugs, fosaprepidan, aloxi, dexamethasone, he was able to tolerate the subsequent infusions. The first scan did show improvement in lung nodule. He had previously been on O2, and he was able to wean down his O2 requirement. Unfortunately, he did experience disease progression after 6 months of therapy.
Did you say what his PD-1 level is? And when you got him, when the infusion rate that worked, like how long did it take to infuse him?
Oh, I don't recall. It was definitely several hours to finish the infusion. His PDL1 score was 2. CPS was
Hmm.
2. Yeah. So I do feel the majority of patients who are claudin positive, now that I've been routinely sending NGS on all my patients with claudin testing, I find that the typical scenario I see is HER2 negative, PDL1 low or 0, and then they're claudin positive. Mhm. We know that there's some overlap, obviously, but that is a typical patient I'm seeing these days.
Yeah, I mean, I think that's kind of what I've been seeing on these Venn diagrams, although I don't know what PD-1 or 2 means. That to me, that could be positive or low. I don't know. How do you view that?
I that's in that gray zone, I would say. Certainly not 0, but at a level where I probably wouldn't offer first line chemo IO for that patient.
Right.
So this was a important opportunity for him.